I have a couple of topics, but not trying to be overwhelmed. A couple of things. So we're going to finish the stuff. We'll finish there's a couple of pages left to briefly talk about for the antimicrobials. We just have to take a look at the antifungals, which are quick, and the antiprotozoans, which are quick, and even a brief mention of the stuff for worms, the antiolytics. We're just getting started. It's okay. It's fine. So nevertheless, with all of that, that's kind of where we're going to be. So that will conclude, other than, and I sent you yesterday morning, I did the second of likely 3 recordings on about this whole, about kind of like host parasite interactions. In other words, how they get into us, what they do to us, why they're bad, toxins, damage to tissue cells, all that kind of stuff. And then the last one of these is on mostly about epidemiology. So those are 3 separate recordings of this quote self-study unit. And then my current anticipation is, from I'm talking to the other group, it seems like Thursday is the day you have the least going on, many of you. Is that correct? Yes, no, good bless. I'm going to try to set this up, not for the Thursday you come back, because I'm anticipating that, I mean, it's a holiday, if you have the opportunity to enjoy the holiday, enjoy it. Because the home stretch is upon us. So rather than have it on the Thursday when we come back, which would be like the 9th, I'm thinking about setting it up to do this Blackboard exam on the 16th. When I know more, and this is the first time we're using Ultra, this Blackboard Ultra, and I want to make sure I'm familiar with the logistics. I might put up a trial one just to see how it works. I mean, it's a little different than we were using the original Blackboard, which was easy to do this with. But Ultra, hopefully, is not any more problematic. So that's a little introductory nugget. The introductory number, easy for me to say. Introductory nugget number 2 is here. We are going to start after we finish this little bit about the antimicrobials, which was, from this other, to basically using that 20 lecture PowerPoint deal that's there. What I'm going to do, if you look under week 4, I have loaded 3 things that are there. So we have this is all on respiratory, and I have some pretty decent notes, about 3 pages for you to refer to. This is one I'll be opening up first. I already have that cooked up, because we're going to go, the last disease, we do 4 diseases. So when I finish doing this little bit on the anti-infective agents, that will conclude the material along with that self-study unit for that exam that we're doing on Blackboard. After this, it's all, once we get to respiratory, it's all final. Respiratory, skin, genitourinary, and wounds. Those are the 4 major topics for the final exam. So it's busy. So we have 4 weeks upon coming back, so each class will be pretty filled with my not so necessarily melodious tones. God, I know. I can see you're ready for another break. I'm looking at you. Terrible. All right, so let me begin and end this first. So this is where I left it. I said, if this is not recording particularly well, we'll work from there. What was your responsibility to see if I started the recording? Did I start the recording? I did. Slacking. You're not, I'm joking. Really, without getting overly wordy about this, because I go into a long spiel, because I know my way around fungi a lot. The big thing with fungal infections and why we treat them, and they're really kind of innocuous most of the time, they're typically on the skin, is because you itch and scratch. That's the big problem with them. And they predispose you to bacterial infections. Same thing with viral infection. A cold isn't necessarily a bad thing, but a secondary bacterial infection, in general, bacterial infections compared to typical viral and fungal infections cause significantly more damage. I'm not talking about a major case of the flu. I'm not talking about some massive skin disease that's part of it. I'm talking about just in general. In general, more permanent and more problematic and even potentially lethal problems occur with bacterial infections. That's the nature of them. So that's really what the underlying thing is here, why we treat them. Of course, there are some more severe fungal infections. That's what we're dealing with here. They tried a lot of different things for fungi, and surprisingly enough, we only have one target. I commented on at the very end of last time we were here on Monday. It's called ergosterol. It's the sterol that serves the purpose of stabilizing that membrane. The big problem with these next three items is they're cells like ours. So they always have side effects. The question is to minimize the side effects. So this is a point of selective toxicity because where there is ergosterol, okay, and we do not have it in our cells, that's a selective toxicity. The problem is there's enough similarity between the cholesterol that gives us problems. And for the most part, in the early days, now there's a whole other area of these different categories of these antifungals. We don't use them. They're all too toxic. They all have significant side effects. They actually caused immunological reactions. They actually brought on autoimmune diseases. They have been nasty. So these are the three categories. Polyenes, which is one of the first ones, and then more recently they've came up with these azoles and alleloamines. It's less important about the names. It's more important how they work, and I'm going to buzz forward. So you can see it here. For instance, this was the original category. It was so disruptive to membranes. Cytoplasm leaked out. And so these were for only, and still is. And this is years ago, when someone got valley fever in the desert Southwest, which is a deep fungal kind of pneumonia. You're treating them with something that literally the cure might have been worse than the disease, even though the disease potentially was fatal. It would cause all sorts of side effects. But now there have been a lot of significant changes, and the category of the azoles particularly have both topical and oral forms that are very, very useful. But give me a moment. The other one of these has been around forever. It's called nystatin. Nystatin was the original agent that was injected with like an applicator, not injected, but applied with an applicator for vaginal yeast infections. It was something we used for thrush, which is a very common problem. These are problems that occur when people who are prone to them, particularly diabetics, particularly with other immunological conditions or underlying conditions, when they take strong antibiotics, if they're women, they get vaginal yeast infections. If they're anybody, they get thrush. Any of you going into clinical fields, you're going to see it. They used to call it the black tongue because it was that bad, foul. Oh, it was awful. I've had it when I was taking immunosuppressant drugs. And now they give you like a throat lozenge that you don't swallow so much as you let it dissolve on your tongue, made out of this called clotrimazole. And you have to do it 5 times a day for like 10 days. It's a lot of lozenges. In the old days, they used to do this, which was called it was either swish and swallow or swish and spit out. That was the old days. Now it's a little bit different. But that's it. I mean, that's how harsh they were. Now, if you go out and buy athlete's foot or fungal skin creams, they're either going to be miconazole or clotrimazole. They're very effective. And what they found out by tinkering with them, they made these two subgroups that are orally active called ketoconazole and fluconazole. The one I have the most experience with is this one. It's known as diflucam, Diflucam, or diflucam, however you pronounce it. Maybe I told you, I used to have my paper charts. Diabetic lady came in, had to give her antibiotics. Little post-it note saying, here, make sure you have a given prescription for diflucam. Because it was that, I never had a problem with it, even though statistically I probably should have. The side effects, never had a problem. Theoretically, I have kidney side effects. And so I thought it was a wonderful agent. All these other guys, we don't use anymore. They created such significant problems. So really, it's all about impeding or blocking ergosterol synthesis. That's all you really have to know about fungal. Protozoans are a little more involved. You recall when we did antibiotics, I was telling you it's awfully hard to find something that treats anaerobes. Anaerobic metabolism is opposite of ours, and anaerobes are really a bear to treat. The best agents for treating anaerobic infections, I mentioned one called clindamycin, which we do use, but really the best one I think is this, metronidazole. And you'll hear it. You may know somebody who used it. The trade name is called Flagyl. It is specific for anaerobic metabolism. It's activated by anaerobic metabolism. That's the beauty of it. And so not only is it classified as an antibiotic because it works on anaerobic bacteria, it works on anaerobic protozoan. These are all anti-protozoan drugs in this chart. So protozoans are very significant. It is the drug of choice, bacteria-wise, for C. diff. You will find for some other anaerobic infections, which we're going to talk about, genitourinary infections, it's also the drug of choice. It is the drug of choice when somebody gets contaminated well water and they get amoebic dysentery or giardiasis, which are very common, but we're lucky around here, and I say it all the time, we have a relatively pristine water supply. It may not taste good, but you're not worried when you get water from your tap necessarily. You're not sitting there, oh my God, I'm going to get sick. Yeah, we have that luxury. Folks with well water, I mean, unfortunately, sometimes that gets contaminated. And really, when this happens, metronidazole is, to me, very easy to tolerate. The biggest single problem is headache. Little kids can take it. They can flavor it as a liquid. All three of my kids got it. Didn't I tell you about that? Okay. I was taking board exams. I was going for a board review course. My first wife came along. We went away for it was like a 4-day course. So we went away to get a getaway. My office manager was wonderful with the kids, loved them. She and her husband, they had a great time. They lived on a farm, they had well water, party time, all that type of stuff. Guess what? They all got probably giardiasis, diarrhea constantly. All had to be on metronidazole. We constantly had to do stool samples. The kids were like 3, 2, and under 1. That was a lot of fun. So thankfully they survived very well, and they used to flavor the metronidazole, make it pineapple, make it bubble gum. So they were very happy to take it. But I think it's a really important agent, and we'll see it is also the drug of choice for a highly significant sexually transmitted disease that you may or may not have heard of, but you'll learn a lot about, called Trichomonas vaginalis. It is caused by a protozoa. So that's one area. The next area, and perhaps the most important protozoan worldwide, is malaria. Malaria, okay, and that's Plasmodium species, are the name of the genus. These came from what are called quinolones. They are quinine alkaloids. They were brought to our attention, when I say our, Western medicine, because they are found in rainforests. Malaria is a disease that's spread by mosquitoes. And where do you find them? Typically where rainforests are. And at the time of the late 1800s, the Panama Canal was being dug in the Isthmus of Panama to connect the Atlantic and Pacific to avoid the long traffic, historically. The people who were digging it, and it was a major excavation, not a lot of modern machinery by our standards. Okay. I mean, cars weren't, that kind of industry wasn't around. Effectively, what happened is people were getting sick because there's a rainforest. And so the natives said, we make an extract from these leaves, quinine alkaloid leaves, and they made all of these. And so these are very effective both to use to treat and for preventatively. If you go someplace where you're malaria prone for a long period of time, they may put you on some of these are used preventatively as well as the usual precautions. Like if you're sleeping it's typically if we go away to a rainforested area or a tropical area, you're normally sleeping at someplace nice, air conditioning. But if you're going to go to one of these rustic ones, you're sleeping in like a little cabin by the beach, that's what mosquito netting is for. It's really important stuff, as well as all the appropriate agents to prevent being bitten. You might remember during COVID, it depends on how much you're paying attention. And I mean, it's getting to be a long, now we're talking 6 years, right about now. There was a lot of controversy, erroneously, it is the preaching. When government and medicine unfortunately combined. Government can't control medicine. Medicine shouldn't be impacting government. A lot of physicians were having success with doing something called hydroxy, one of these quinolines, like hydroxyquinine related structure. They were using this. A lot of these anti-malarials and something called ivermectin, which is an anti-worm agent, were being used because we don't know how they work, but they're very useful for anti-inflammatories. A lot of physicians were having, and they were being shouted down, threatened with being medically losing their license for using hydroxyquinolines and fibromycin as antibiotics to treat COVID, despite having an enormous amount of effect. So I don't want to go into the politics of it. I'm just telling you the reality of it. The realities of it. Okay. Ivermectin, they were yelling, "Oh, that's horse paste," and it is. And you give it to horses because it's the same stuff, except in horse paste, they give you a dose for a 1,000-pound horse, not a 150-pound horse. If you use the horse's dose, you're going to get real sick or die. If you take a quarter, a fifth, an eighth, a tenth of that dose, it's highly effective. I mean, I had discussed that with physicians, and we would sit there and say, "Yeah, it works. We don't know why it works, but it worked." They did a lot of studies. I mean, so it has a lot to do with the vaccine program. It had to a lot of things they would do. I don't even want to go into it; so it aggravates me. You'll see when we get to respiratory, we'll do a little unit on COVID. That is there. So I have a separate PowerPoint that they produce, that our textbook produces for that. So I want you to be aware that it has a multiplicity of uses, but believe me, malaria is a monstrous disease that we rarely see in this country unless someone has contracted it from overseas. It is the largest single killer in sub-Saharan or equatorial Africa. Not AIDS. AIDS is second. Measles, by the way. Get to that. So that's something else I should remember. Those are the two, really, the take-home ones. And just for context, I don't know a lot about these kinds of anti-helminthic for worms. Here's the ivermectin. And so understand, and any of these, mebendazole, thiabendazole. So if you've got a dog or a cat, for dogs around here, you got to treat for heartworm, preventative. And you'll see it's typically ivermectin and one of those bendazoles. And a chewy tab, you give once a month. And then you should have a flea and tick, either a flea and tick collar, or you should have some type of flea and tick medicine you could rub in and absorb through the skin. We use a Seresto collar. Not all dogs tolerate that, but we're fine with that. It's a big problem. We'll talk about Lyme disease when we get to that. That's when we start getting to these insect things. It's very interesting, and really, that's the end of this. So we're done with that. Thankfully, now we have a good introductory 25 minutes or so to talk about respiratory. And I understand, I have been told, informed, perhaps erroneously so, by the people in the first group at 9 o'clock, that you have actually done respiratory. And you're verifying it. Toria told me she did. And she would never falsify evidence. Okay. So I don't have to go over the anatomy, and I'm not going to. I'm going to highlight some of the stuff that's important. Here's the backstory. The number one in diagnosis we have in medicine is URI, upper respiratory infection. Broad brush. Broad brush is upper respiratory infections are generally not big problems. They can be annoying, but they're typically not life-threatening, though some are. We'll address that. Lower respiratory infections, just the opposite. When we talk about pneumonia, tuberculosis, severe bronchitis, those are things that can very well be life-threatening, but sometimes they are not. So that's the broad brush stroke. Upper and lower, to me, the anatomical, and that's when I do AAP, is the larynx. If you have to have a cold that starts here and you end up with laryngitis, upper. If you start with laryngitis, next thing you know, you have bronchitis or pneumonia, low. Okay. And so and a lot of this impacts the other. Remember the functional division between the conducting and the respiratory, the exchange division? If you had AAP2, you had that. That's a little bit different. Here's the interesting nugget. So the bug du jour, sort of the most important bug that we talk about, and interestingly, as a bacteria which usually work through toxins, this particular bacteria works through your immune system much more than anything else. And it's called, proper name, group A, beta, and you did this in lab. That's why it ties in so beautifully this week. Beta hemolytic Streptococcus pyogenes, which means pus producer. That's the formal name. Dr. Lansfield was studying, I mean, this strep throats, rheumatic fever, scarlet fever, all of these come from this particular, it's a devastating bacteria with a lot of problems, and most of the time through the immune system. And she was trying to figure out, wait, what you did in lab, you planted it out on blood on, and you looked at different flavors that were there. You had beta hemolysis, which means you could almost hold the light, see through it, gobbled all the red cells. When it just started to really change its colors to kind of greens and browns, that's alpha or partial hemolysis. And then some are non-hemolytic. And when I was talking about Enterococcus, VRE, that I talked about on Monday, that's a non-hemolytic streptococcal cousin. So it's not alpha beta, that's called gamma, which is really non-hemolytic. She said that, and she had recognized that hemolysis was not an easy way to predict, because what other tests did you do in lab? I know you put discs on it like bacitracin. There's more. If you do a throat culture and they send it to the lab has strips on it, dots, antibiotic discharge. Your tests for multiple things. But you put some drops of peroxide on it, correct? Right? Or you haven't done that yet? That's the bubble test, called the catalase test. Because Staphylococcus aureus and Streptococcus pyogenes are frequently both hemolytic. The problem is, how do you distinguish between them? You distinguish between them because Staphylococcus aero, Streptococcus pyogenes is categorized as a aerotolerant, but it does not make catalase, as little superoxide dispute. That's why the bubble tests work. It's a basic differentiation between Staphylococcus and Streptococcus, which look, they're gram-positive cocci, they look alike. Okay, this is what part of the way we tell them apart. That's the information we're doing. So she was looking for something that was even more effective, and she was looking at carbohydrate markers on the external shell, on the external cell wall, and all these bugs have a lot of them. And she saw these short-chain carbohydrates, just like our APO blood groups, that serve as an identifier. And she classified them using her name, which scientists always do with Lansfield, and they bear her name today. And that's the basis of the rapid strep test. Rather than have to do a culture, it's going to take 24 to 48 hours. You basically can do the throat swab, take the little swab portion, the sterile Q-tip part that's got the stuff on it, and stick it into one of the systems, a la COVID test. Read that with the nose, that COVID system. And just like the COVID thing, you'll see a dark line that'll indicate the test is working, and a second dark line will show up if it's group A positive. Then you pretty much have a slam dunk. This is a strep throat, and you start treating them. If the culture doesn't bear that out and it's a false positive, okay, that's a different story. But at least that's your empiric evidence to start treating. She was all about that. And you can see, it's wonderful. I love that they give credit, particularly to ladies in science, which has not nearly been the case. It's really a problem. So this is what it looks like. Trivial to fatal, upper respiratory. We'll get to the ones that are potentially fatal. Different than lower. That's a classic inflamed or injected, we often call the term, throat. You can see the uvula. You can see the distinct red color. I mean, if you probably would see little tiny pustules on those tonsils that are so enlarged, that's what you would see. In your age group, for most of you, the differential diagnosis and college students, if that strep test is negative, would be mononucleosis. Mononucleosis is what we call a masquerader. There's a lot of lookalike stuff. I know that because my stepdaughter, when she was in college up at Allegheny College in Meadville, they were saying, "You got strep throat," and they finally said, "Not working." They did the test for them. I forget which first or second year of college. So that's kind of what they look like, and that's where when you do the swab. So technically, you guys didn't look in there, but that's the whole idea: the tongue depressor and good light to be able to see that. And this is all. I mean, this is the basic physiology. I summed it up when I did that lab demo for Dr. Robbins last Wednesday. Respiratory can be summed up easily: in with the good air, out with the bad. It works. What else does it do? And so all of these things are absolutely true. The problem is there's anatomy that is a problem. So maybe you reviewed the anatomy. We have there what? Trachea. And the trachea divides into the two main bronchi, right? Primary or main bronchi. 3 on the right, 2 on the left. I got it. Why are they different? How are the two main bronchi different? It's a very significant feature anatomical. It's what I call an anatomical basis of disease. I love these. Okay. On the left, what's on? You see the lung on the left? See that big indentation? What's making that indentation? Heart. You got to have heart. All you really need is heart. The heart's there. And so what happens, the bronchi can't go straight into the lung. It's got to make a left turn and go over it. So at that point, it's very vertical. It's much more horizontal. On the right, straight in. Pneumonias has to do with gravity, particles that come down. Which side are they more likely to go on and infect, the right and the left? That's the reason we see more right side of the bone than left. In a really bad case, you'll get what's called double pneumonia. Both lungs are involved. More problems on the right. There's a lot of different pneumonias. I don't know if you did them. We have aspiration pneumonia. That's the reason for the single most important, you guys going into nursing, the single most important preoperative order. None of the others have any credence whatsoever because you can always redo them. Called NPO, midnight, non-pars oral. Nothing passes in the mouth at midnight for surgery in the morning. Because if it's something in your stomach, you can regurgitate it. It'll go up like a geyser and come back down. Recovery because your line's not your bad. You and I, if we're sleeping, all of a sudden feel like you got to spit up something on your head. You can't do that when you're still gorged. That's the reason. NPO midnight. The only thing you can't fake. When somebody comes in, we have to operate off the street. Oh, we got to take them to, you put a nasogastric tube in to prevent that. Nasogastric tube in, catheterize them, IV, you're ready to go. Because you don't have the luxury of somebody got shots, stabs, internal biopsies. It's kind of, it's interesting. But they didn't have their blood test, you can get them. They didn't have an EKG, you can get them. Get a medical consult, get a chest x-ray. This stuff. Don't believe me, I actually used to do this stuff. I have no idea what this doesn't pertain to me. The other anatomical basis disease, you have a wonderful area that's the source of the first area we're going to discuss, because we're only going to go through the introduction here. What happens over here, that's the nasal cavity. It's bigger than you think. So you have different passageways in and out. You have the lacrimal duct. Remember that from anatomy? The lacrimal bone, lacrimal caruncle. You can put your little finger on there. Tear duct. That's a two-way passage. Stuff can go from your nose out. In adults, major problem with conjunctivitis, colds. Because you can use that passageway out. Little kids, dirty angioedema. So that's a potential passageway for infection. It has a variety of sinuses. Remember the 4 sinuses. The acronym is FENS, paranasal air sinus, frontal, ethmoid, maxillary, and sphenic. And those are, you make up your own acronym, mine works. And those are little cul-de-sacs that get inflamed. Again, viral infections, the big problem is secondary bacterial infections. About 1/3 of the infections are viral, and about 2/3 are bacterial. The trouble is bacterial fluids are more damaged. So they clog the cul-de-sac. They're very painful. The pus, the drainage kind of takes some, maybe you've seen some fairly vivid colors when they get infected. Yuck. And the last, and certainly the most important, because they all come from the nasal cavity. So the organisms that cause these are all pretty much the same or similar. There's really two prominent ones that we'll identify. And that one is very famously the eustachian tube, or auditory tube, or pharyngotympanic tube over here someplace. Yeah, it's not the best diagram. That's the tube that leaves where? What chamber does it go to? See, you took anatomy and physiology. Did you study the ear? There are three parts of the outer ear. It's a multiple choice question. Outer ear, middle ear, inner ear. Where does the eustachian tube open up into? The outer ear, the inner ear, or the middle ear? Middle. Eardrum here is the boundary of the outer. Do you remember oval windows and round windows? There's the three stooges in there. Three bones: Incus, Malleus, and Stapes, hammer, angle, and stirrup. Pep Boys, Manny, Mo, and Jack. Rather than Mo, Larry, and Curly. Slightly. I'm a big Three Stooges fan. They have a great one on Prime right now. Go see it. It's free if you have Amazon Prime. It's the backstory, told by Mo's son. An hour and a half documentary on how they got together. The Horowitz brothers from the Lower East Side, New York. Sam, there were four, but Sam, Morris, and Jerome. The guy they knew, I think they were related to, named Louis Feinstein. When I was a tie-wearing professor before I came here, okay, I was a tie-wearing one. I had a tie that was all Three Stooges, like on the golf course. You guys are no fun. So why am I getting this big story about the middle ear? Little kids, who gets ear infections? Many of you had otitis media. Some of you might have had tubes in your ears. Okay, all of you end up taking amoxicillin if you aren't allergic to penicillin, because little kids get ear infections. It's anatomical. In little kids, that tube is like this. It's horizontal. When the baby sleeps, any kind of stuff that's dripping, that's got viruses or bacteria, where does it go? Back to the middle ear. It gets jammed up in there. And it gets infected. As by roughly starting around age 4 and a little bit after, as the baby grows, that tube becomes more declinated. And so when they're sleeping, it doesn't back up. It's an anatomical basis of disease, the orientation or the structural orientation, going from horizontal to more vertical. That's all. I mean, I don't know about you. My daughter had 2 sets of tubes, one at age 2, one at age 4 will go into the tubes. The older of the two boys, he ended up, we didn't have tubes, had a lot of ear infection. The middle one did. And both of the oldest and my daughter ended up having their tonsils removed. You generally don't remove tonsils because they're immunological tissue. They protect you unless they become a source of infection. And they started to become necrotic or diseased and dying, and they were actually seeding other parts of the body with infection. So, I mean, there's a whole lot. So, I mean, we're talking about something relatively innocuous like an ear infection or not. When we were kids, my age, if you had two ear infections, they took out your tonsils. They thought it was all about the tonsils. Oh, if you had an ear infection, that's the third one. Oh, how come the tonsils? I had mine out when I was 5 or 6. That was routine. Big tummy ache, they start yanking out appendixes, or appendices is the appropriate plural, because they didn't know any better. That's immunological tissue. It's there to protect you, not to hurt you. You know, you wouldn't take away your defenses. And then you've seen a lot of this stuff. A lot of these things, it's about, particularly in upper respiratory and even lower respiratory, it's about that, the mucociliary escalator. Remember the epithelia that's part of that? That was last term. And then lining cells. Was it columnar? Was it cuboidal? You got to learn this stuff. I'm a nut for epithelia. Does this ring a bell? Pseudostratified, columnar, ciliated epithelia with goblet cells. Ringing a bell? Yeah. That's the characteristic epithelial cell or lining cell. The cilia, the mucus, the goblet cells produce the mucus. Mucus is sticky. It traps all those bad guys. You should learn about this with immune system. And what happens is the cilia beat it in from, if they're nasopharynx, toward the mouth, oropharynx forward to expel or to swallow, somehow get rid of laryngopharynx, up and out. All of that. That's how they work. If you compromise that escalator, you're really predisposed to a lot of problems. The obvious one is smoking. I can attest to this. Thank goodness, I rarely get now. I mean, I'd have for months residual bronchitis from a common cold. Unfortunately, I don't get it very much, all because of that. And so these are then with the role of the sinuses and stuff like this. Again, the epiglottis is that, and this is respiratory anatomy again. The epiglottis is the one that's made out of what kind of cartilage? Hyaline, fibrous, or elastic? God, thank God you didn't have me for that. Elastic. There's only two types of elastic cartilage. Boink, your ear, and the epiglottis. All the other cartilage effectively is hyaline in the respiratory tract. Most abundant of the cartilages. See, it's very important to retain info. Those are the kinds of things that are part of, and I'm not yelling and screaming, you know that. But when you talk about prerequisite knowledge, you're supposed to have a passing knowledge of something that you have taken. These are things you must learn to recall. Because it's not something you're probably going to study when you go take a licensure exam. Hopefully, the bell rings. That's why I make a deal out of it. But epiglottitis, because it swells, you can't breathe. Big problem. Because it blocks the passageway into your lungs. That's the cover when you swallow something. Remember your mom said, don't talk and eat? That's why. So here, these are called normal flora or normal microbes. Microbiota. They are not innocent. Look at the members of this Streptococcus, gram-positive cocci. We knew that. Aerotolerant. Why it doesn't pass the bubble test. Viridins, alpha hemolytic. We don't see beta hemolytic Streptococcus pyogenes, but about 1/3 to 1/2 of us have strep pneumonia. There's a disc you could put on, you probably didn't, called Optochin. I ordered some. They're probably not good anymore. Years ago, when I pretty much the lab. It's called Streptococcus. It's one of those partially hemolytic or alpha pneumonia. It is the leading cause in adults of bacterial pneumonia. We don't die from the flu. We do die from secondary bacterial pneumonia. This is most frequently the cause, 60 to 70%. Streptococcus pneumonia. Staph aureus. 30% of us normally have Staphylococcus aureus, a known pathogen, in our nose, including MRSA. Again, if you work in a hospital environment or a clinical environment, twice a year, you're likely to have MRSA. You're not going to die from it. You can just treat it topically, periodically where you're working. They may swab your nose. We swab patients' noses. And the reason is, if they develop MRSA, basically you can say, well, you brought it with you. Don't blame me. Maybe to me, I don't buy that. But again, this is all a lot of what medicine has to do with liability and insurance companies, understand. There's a reason why they'll cancel school some days and some days they won't. Because if it's too slippery for you to walk and you fall, it's their fault. And you can take appropriate legal action if you choose to do so. Here's another one. And so we have, these are corynebacteria. You have them on your skin. You have them everywhere. They are gram-positive, non-endospore-forming rods. Very important. We will get to the most important one of these because it has to do with a disease called diphtheria. Since these are not causing diphtheria in you, they're called diphtheroids. They look like it, but they're not diphtheria organisms. These are a whole other, so we have gram-positive rods, gram-negative rods, other gram-negative rods named Haemophilus, gram-negative cocci, gram-positive cocci, everything. If you did a gram stain of that thing you put on blood agar, you'd find every kind of positive, negative, different shapes and sizes. So the big one in that's important is called Haemophilus. It's a small, relatively easy to kill gram-negative rods. It bears the last name Haemophilus influenza. You got that name because they thought, since we all have it, they didn't know that, and they were testing after the great flu epidemic of 1918 and 1919, which is the single largest epidemiological event killing people, the single largest microbiological killer of all time, proportionately. Well over 100 million people died worldwide. They'll give you different numbers. There's a great book about it called Flu, which was written by at the time, she was the science editor of the New York Times, named Gina Colada. I have the book. It's a little thin book. And she traced it as a biology. She did like an investigative. She was like it was like a detective novel. And erroneously, they thought, oh, we didn't know about viruses. So they didn't know that there's this bacteria that's really tiny and sometimes hard to grow. And they named it Haemophilus because you had to grow with blood agar, the hemo, and influenza because they thought it was the cause. Turned out it wasn't. But these two are potential pathogens. The vast majority of us have them both. I would say more, certainly this, almost all, this, a third to a half, have these. And the causes for bacterial conjunctivitis, sinusitis, those are inflamed sinuses, affected, and middle ear infections, otitis media. These are the two most common causative agents. About a third are viral, about 2/3 are bacterial. They are the reason, and we will get to that when we talk next time, about why we use amoxicillin if someone's not penicillin allergic. It's there. It has to do with a lot with them. These are the guys, and we find them normal. So that's a very interesting thing about upper respiratory. Even though these are normal, and when you'll see when we talk about bite wounds, we'll get to the mouth and see why there's such a problem when someone is bitten, a human bite. Dog bites also are obviously dog bites and cat bites, which are a little bit different, but similar in that regard. Treatment is about the same. So, I mean, this is just looking at this conjunctivitis. No one doesn't have bacteria. Otitis media. We'll talk about, and this is the lower areas and you can read through this. To me, it's not anything. It's just basic anatomy and physiology. This is where I stop with the other groups. So we're going to start talking about these three: conjunctivitis, earache, otitis media, and bacterial and viral sinus infections when we meet after the break. Have a great break. All appropriate break. I hope this came through. We will see. I'll be cautiously optimistic. Bye-bye. Thank you.